Welcome to ChalkWalks. In this case, we're going to discuss a 10-year-old male castrated Chihuahua who has a history of having developed a cough about 3 months ago, and it improved with an unknown medication provided by the referring veterinarian and humidification. But his cough redeveloped in the last couple of days, and he developed a new finding, which was loose bloody stool. Fecal exam was unremarkable, and he was placed on an unknown antibiotic at that time, a probiotic, and a GI diet. But today, he appeared to the owners to be disoriented and blind. In fact, they did the referring veterinarian looked at the dog and just dropped a cotton ball in front of it, and it obviously didn't see it. So they referred to ophthalmology. And on physical exam, the ophthalmologist discovered that this dog had hyphema in both eyes and flare, or evidence of inflammation in both eyes. Perhaps just as notably, they detected enlarged and firm mandibular and prescapular lymph nodes, mandibular and prescapular, and popliteal as well, large and firm. They went ahead and proceeded to get a CBC, which was pretty unremarkable, a slightly low hematocrit perhaps. Went forward with a lymph node aspirate from the right mandibular lymph node, and the pathologist reported out atypical lymphocytes. Biochemistry was unremarkable, and UA showed a few epithelial cells and rare bacteria. The diagnosis, combining that of the pathologist and the ophthalmologist, was anterior uveitis in both eyes and lymphoma, and they felt like what was seen in the eye was consistent with, and of course in the lymph nodes, was consistent with multicentric lymphoma as a diagnosis. Further staging was not performed, but just to indicate what that might have included, radiographs, chest radiographs might be indicated to stage the animal, although it was clear that it was multicentric. Ultrasound is often used to evaluate the animal's other sites, and sometimes bone marrow. This dog was not yet anemic and certainly was not leukemic with regards to its type of lymphoma. Now we know that lymphoma exists as B and T cell, so we have basically 75% are B cell lymphomas and 25% are T cell lymphomas, with a better prognosis for the B cells with a reasonable multi-drug protocol. You can expect, now they're saying somewhere between 12 to 14 months compared to maybe 1 to 2 months at most for untreated. And T-cell lymphomas generally 6 to 8 months prognosis, on median prognosis. So the owners agreed to proceed with a protocol, a multi-drug protocol for treating lymphoma that would extend the lifespan of the animals. And I think it's first important to know that our goal is a good quality of life. And this may appear to be somewhat in contrast to what occurs in more aggressive therapies in humans, although those therapies have become much more tolerable as new types of therapies come on the scene. For the protocol that was chosen, it's called the CHOP protocol, and we'll go through what each of those letters stands for in a minute, but this protocol generally can go anywhere between 15 to 25 weeks, and on average just to give you an idea, will cost the owners about $3,500. In this case, this dog was, on the day of being examined, was treated with a topical eye ointment, mainly for the purposes of reducing inflammation, and we'll get to that in the next slide. It did have a glucocorticoid in it, but I wanted to focus on what they also did on what we'll call the zero time here. And in that time, the dog was pre-treated with an H1 antagonist, diphenhydramine, and that was to prevent or at least ameliorate an allergic reaction, because the dog was also given the enzyme L-asparaginase, and this is given intraperitoneally. L-asparaginase is targeted. We're going to list that as a lymphoma-specific treatment. So L-asparaginase is lymphoma-specific because asparagine is generally required by lymphoma cells, and they cannot make this amino acid by themselves. So if we destroy that, it becomes a selective treatment. It's generally used to sort of jumpstart the therapy, and is given one time. Animals can have an allergic reaction, so that's why diphenhydramine was administered. It's not part of any of the chemo protocol. That's what I have it in pink. The dog was also started and sent home on prednisolone, glucocorticoid, of course, and this was at what we call an immunosuppressive dose. Also tends to be used initially in chemo protocols. Now, this drug, because the glucocorticoids act through nuclear receptors, we start with high dosages and taper down. It's generally felt that if you use glucocorticoids alone in an animal with lymphoma, it could be effective. It could be a way to successfully and relatively cheaply buy some time for that animal, but because of the inevitable desensitization of the receptors, basically you result in lack of efficacy of glucocorticoids after usually around 6 weeks. So we can say by themselves around 6 weeks, this would no longer help to control the animal. In fact, generally what was told to this owner of this dog was that if they decided after the first week or second week to not continue therapy, they should continue glucocorticoids at somewhere around this middle dose down here in the second week, and continue it indefinitely until the animal didn't respond anymore. So basically they started the animal on L-asparaginase, prednisolone the entire week, once a day, and then what we call the CHOP protocol began, and we're going to start with vincristine, which is also known as Oncovin, and that's the O. So that's right here. Oncovin is the trade name, and we'll just put a little R there to remind you of that. So that is given IV once, and where does it work? It's useful for me to review the cell cycle, and so let me start with the M phase. We'll talk about that with regards to vincristine's action. It is this is the mitosis phase, and then we go into the post-mitotic G1 phase. You can have the possibility of moving out of that into a resting phase, or through to a synthesis phase, and then to pre-mitotic phase. So we're going to talk about drugs that work at specific points on this site and those that are cell cycle nonspecific. And we've already talked about one that's lymphoma specific. So going back to vincristine will work at the M phase. And what does it do? It basically is a mitotic spindle inhibitor. And by inhibiting the ability of cells to essentially divide, they lead to a block, if you will, at the transition from the mitotic phase to the post-mitotic phase. And what does that accomplish? Well, it allows all cells to be sort of piling up at that phase. It slows them down. You can see we give it once periodically if you look at the protocol on the right. And it puts all cells in a lockstep, not all cells, but most cells that are dividing into stop at that G1 phase. And it allows cell cycle nonspecific drugs, and the ones that we're using in this protocol include cyclophosphamide and doxorubicin, are going to have greater efficacy because they follow the alignment of these cells. An analogy would be if you want to have the greatest effect on killing, individuals coming into a room, have them line up at the door and then get out a shotgun. It's a pretty brutal analogy, but hopefully you get the picture. And because many aspects about chemotherapy are almost that brutal, because the issues are side effects. If you let them come in one at a time, you might be killing more students that are in the classroom, as a side effect, et cetera, et cetera. So that analogy is to reduce side effects, maximize the killing of these, accomplished by the very nonspecific cell cycle, nonspecific drugs. Glucocorticoids were also continued, prednisolone at a slightly reduced dose. I should mention that technically these are also lymphoma specific in terms of cancer chemotherapy, so let me put prednisolone down here in that category. And why is it lymphoma specific? Well, we know that glucocorticoids are lymphocytolytic. We know that from the effects. If you think about a stress leukogram, you have lowered lymphocytes amongst the various things you can see on a CBC. And that's why many oncologists would prefer that you not refer a case having been on glucocorticoids before an actual diagnosis made histologically or at least by cytological means, because you can alter that histology and obfuscate an appropriate diagnosis if the animal's already on glucocorticoids. All right, so we've lined the animal up. Week 1, we've used 2 lymphoma-specific agents, started the prednisolone protocol, which will continue down to essentially through a full 3 additional weeks, or 4 additional weeks. And we are now going to have the animal come back and it receives cyclophosphamide. Now, it can be given PO or IV, but the side effects, mainly being urinary, bladder, cystitis, drug-induced cystitis, is reduced if it's given orally. And this drug, cyclophosphamide, is an alkylating agent. And it's, as you can imagine, if you're alkylating, it alkylates DNA. So it's going to have its effect really throughout the period. We'll call that relatively nonspecific, so cyclophosphamide we'll put here. But of course, it really has its damage at the synthesis phase. So cyclophosphamide and the other drugs, when we say nonspecific, are really impacting from here all the way over to here because they're altering the replication of DNA. Continue the prednisolone, go to the next week, say we've got to line the cells up again, we repeat the vincristine, continue the prednisolone at a lower dosage, and then on week 4, you can see we use doxorubicin. And basically, doxorubicin is also nonspecific, And where does it stand? Let's see, D in the CHOP. It's basically hydroxy, and it's also called hydroxy Doxorubicin. And that's where that's our H. So we've talked about C, H, O, and P already. And that time we discontinue the prednisolone, and then we enter back into another cycle. Now, a couple of comments about why this protocol can be effective. Well, first of all, cells can become resistant to drugs. So if they become resistant to the treatment of by cyclophosphamide, because you've given a fairly general agent that can affect a lot of cells and have side effects, you can, given multiple times, if you continue to give it, you're going to see eventually cells that develop that are resistant. We already know this with the prednisolone. Secondarily, you have different kinds of side effects. So with these drugs, cyclophosphamide, I already mentioned the cystitis, but you're also going to have reduced white cell counts in the animal. Can be severely neutropenic, so you're going to follow the CBC. And because all replicating agents are affecting multiplying cells, where are those multiplying cells? Bone marrow and gut. So the other side effects you'll see are GI side effects, bloody diarrhea. This dog already has that, perhaps because it has lymphoma in its gut as well. So now doxorubicin is, as we said, is DNA intercalating agent. And it gets, it basically goes between DNA and prevents its replication. And there are different kinds of ways that the cells can become resistant to it. We use it. We mainly given every 2 to 3 weeks, a maximum of 6 doses, and the reason is its side effect is mainly cardiotoxicity. And so if you'll see that there is a maximum dose, usually around six doses max, and you'll want to monitor the ECG in these animals. So it has cardiotoxicity, and therefore you want to max out the dose. It's usually dosed on a per meter squared basis because of that. You want to make sure you get that dose correctly. So that's the CHOP protocol that was used in this dog and is used in many dogs. It has a reasonable prognosis to extend the life of the animal, particularly for B-cell tumors, as long as a year or more. And if the animal was untreated, it would only survive perhaps a month or so. Finally, I wanted to not forget that there were other therapies that were used in this case that are worth talking about. The ophthalmologist for the first 2 weeks initiated, before the full protocol to treat the lympho was in play, with a topical neomycin, polymyxin, dexamethasone. Well, dexamethasone is a glucocorticoid, and that certainly is going to reduce the inflammation. And uveitis, it was felt to be in both eyes. That's why the animal was treated in both eyes. Neomycin is an agent that's very good at gram negatives, a bacterial agent, and polymyxin is an agent that's good against gram positive. In addition, the animal was treated with atropine, which is an antimuscarinic agent, and the reason for that was when you have inflammation in the interior chamber, which is what uveitis is, it's useful to dilate the pupil, and that's because you can reduce the tendency for the ciliary muscle, or the iris, I should say, from binding to the cornea itself as inflammatory tags develop. and so you reduce the tendency of synechia. It also, of course, prevents eye pain, if you will, because much of that pain can be caused by spasm of the ciliary muscle, which is involved with dilating the eye. So, with constricting the eye, so you're blocking that spasm, you're blocking the action of that muscle. And that is used, in this case, only in the affected eye, twice a day until effect, and then you usually back off on it. On week 2, because of the initiation of the animal having some chemotherapy drugs coming along and that have GI side effects, as well as the fact that the dog continued to have some bloody diarrhea, they felt that it was important to treat the animal with an Ropitant as an antiemetic, and that's an NK1 antagonist, so a broad spectrum agent. It works at the emetic center. And also metronidazole, which is an antimicrobial directed at anaerobic bacteria and protozoa. So whether this was the case or not, they did not find any of these on culture, or there certainly weren't even parasites found on the fecal exam, but this was used to manage the GI signs, and inflammation was clearly evident from bloody diarrhea. And so the other characteristic that metronidazole has been purported to show is that it has anti-inflammatory properties in the gut.